I've always wondered what happens if you say no with recording in progress. I don't know if I could have pulled that one off this time, but anyways, nice to see everybody. It's a holiday. I'm sure we probably all, maybe not all, but we have things we'd like to do. So we'll see. We don't have any cases today. Full disclosure, this probably isn't my greatest work because I made it while I was pretty sick last week, but I'm hoping that we'll all have some informative stuff. If anybody wants to participate, ask questions during it, please let me know. I figured this is kind of be a nice presentation for us to all sort of chat about in a way about some stuff. So let me share my screen as I was delaying so I could share it. Okay. All right, is that coming through okay? All right, very good. All right, so this is dosing the medications for opioid use disorder. You can never really tell where we're going with the parlance, whether we're calling it MAT or MOUD or medication-assisted therapy or whatever we're calling it these days. But the point is medications that help folks that struggle with opioid use. That's me. I work at WVU. I also have some other hats that I wear. And it is Valentine's Day. All right, so disclosures. I don't really have any relevant financial disclosures. I don't have any ties to the pharmaceutical companies that make any of this stuff. In fact, I get them upset sometimes, some things I say. All the medication we're discussing is they're FDA approved or they're about to be approved for treating opioid use disorder. What I mainly do is, again, I work at WV Medicine on the dual diagnosis unit, also the addiction intensive outpatient program. I also serve as the president of the West Virginia Society of Addiction Medicine. And notably, I do this provider clinical support system. Some of you probably, this is how you got your buprenorphine training, if you've already had it. And some of the slides, several of them I've kind of stolen from there. But I felt that they were relevant and helpful when it just comes to discussing the three main MOUDs. Okay, so the objectives of this are to consider the medication options for opioid use, of course. We'll talk a little bit about the dosing of these medicines. There's lots of different ways to dose. It's very provider dependent. I wouldn't say that I'm trying to give everybody, the exact way that everyone should dose all the time. It's going to come down to clinical judgment, as it should, and patient by patient basis. There are some much more involved things that we can do in the future, kind of cutting edge dosing regimens and things that some of you all might have tried, maybe you haven't, maybe you have. Feel free if there's things you're interested in. We're not going to be talking about kind of really interesting cross tapers and things, maybe briefly mention that, but that's a whole involved thing and something that we've actually talked about writing up. We're going to talk a little bit about the efficacy of medicines. Certainly they are efficacious. Some of them work better for certain things than other things. We'll talk about that. And a little bit into the acceptance of medications as part of standard treatment. We all realize, hopefully everybody on this call realizes that medications are the standard of care for opioid use disorder, but of course not everybody follows standard care, whether it's an addiction treatment or any treatment within medicine. And then lastly, we'll do kind of a quiz on cheesy romantic movie lines, given that it's Valentine's Day. So we have some slides about that, not too many, just a few. So to start it off appropriately, about three things I was absolutely certain. First, Edward was a vampire. Secondly, there was part of him, and I didn't know how dominant that part might be, that thirsted for my blood. And third, I was unconditionally and irrevocably in love with him. Anybody want to take a stab at this? We're not doing any actual Zoom polls.
Twilight.
Okay, yes,
I'm guilty. I liked it. Don't judge me. Okay. I've watched it lots of times.
I am judging, but you are correct. All right. Very good. So very cheesy quotes and wonderful. All right. So there won't be too many of those if you guys are already getting bored with that, but medication assisted treatment or MOUD, whatever we're calling it, it is the gold standard of treatment for opioid use disorder. And it's the only efficacious and ethical medical treatment available. So if you're talking about it from an ethics standpoint, if you're a doctor and you say, I don't believe in MAT, then you don't really believe in ethical opioid use disorder treatment, because it's the only thing that really benefits people, keeps people alive, at least from a medical point of view. So if you're going to treat OUD, you need to use medicines of some sort. Every professional addiction society recommends using these medicines. The AMA recommends it. Anytime you see anything, practice-based this or gold standard that, it's always to use medicines. So people like AMA, SAMHSA, ASAM, part of AAAP, all these people, absolutely medications are the way to go. There's 3 that are approved. They're all considered first-line treatment for OUD. Again, some have more evidence, longer evidence, some have better evidence for certain things than others. So methadone, lest we forget methadone, which I will talk about a little bit because it's not something we discuss so much. Just so those are everyone's aware, methadone, there's, we still have this unfortunate banning of, you can only have 9 methadone clinics in the state, and that's something that obviously needs to change, because methadone is a very viable option for people. Naltrexone was the second, which we'll talk about, and then buprenorphine, our friend that we often talk about in ECHO. Keep in mind the primary goals of MOUD treatment, whether you're a physician or a nurse or care manager. The end goals are, we want to decrease morbidity and mortality. So we want less people suffering, less people dying by use of these medicines. And then if we're keeping people alive, let's increase their quality of life, give them back some of the life that they've lost as a result of their use. So a little bit into the milestones in MOUD treatment. So really, these have not been around all that long when you consider the history of medicine, but methadone was not approved for detox until 1970 and maintenance until 1973. So really only 49 years that we've had methadone available. Before that, it was illegal to treat opioid addiction with any kind of opioid medicine. OTPs didn't start until 1974, and they still exist to this day. And oral naltrexone was approved in 1984, which was originally, it was actually approved for alcohol and not opioids, which is always interesting. It wasn't until 2000 that we had the DATA Act, which allowed us to prescribe medicines through outpatients, office-based medicines, actually prescribing partial opioids, specifically medicine FDA approved for addiction treatment, of which buprenorphine was really the only one that fit that category. So DATA 2000 did not permit us to prescribe methadone out of a regular clinic, but it did open the door for buprenorphine, which was approved in 2002. It wasn't until 2010 that we got an extended release injectable naltrexone, of which we only have Vivitrol. And then in 2016, which really is not that long ago, this is really what opened the door to our colleagues or nurse practitioners and physician assistants to be eligible to prescribe buprenorphine. Before that, it was only a physician that could. And this has really helped and allowed other people, including some people on this call, to be able to do it. That's helpful. All right, so comparing the 3 medicines, we've talked about this before, but the pros and the cons. So the pros of methadone: lasts for a long time in your system. You only dose it once a day for opioid use. It's been around for a long time, since the 70s, and before that in studies, we've been using it for a long time. It certainly helps with pain. It's a full opioid, so why wouldn't it? And it does lower overdoses. So there's lots of evidence that people that are on methadone, they're much less likely to die of an overdose because methadone's keeping them stable. Bup, obviously, we can do it in a doctor's office, makes it a lot simpler. Less risk of, minimal risk of overdose from the medicine itself, and it lowers overdoses as well. There's less risk of IV use, not no use, and no risk. It does help with pain, and it is fairly simple to get somebody on buprenorphine. Naltrexone, what people like is it's not diverted. There's no risk of overdose from naltrexone itself, which is good. There's no dependency to naltrexone, and there's minimal stigma, not no stigma, but minimal. Not would be double negative. We'll avoid that. Cons of methadone, of course, it's inconvenient, so you have to go to one of these OTPs. Possible diversion, It's kind of hard to divert methadone unless you're getting take homes or you're getting it as a prescribed for pain. That's where a lot of diverted methadone comes from, is that which is not really prescribed from OTPs. It is lethal in overdose. You can certainly die from methadone. There's a pretty rough withdrawal from methadone at times. The long half-life is a pro and a con in a way, because it's a difficult medicine to get out of people's system and get them switched over to one of these other ones. It's usually easy to go from naltrexone up to bup, and from bup to methadone. Much harder to go the other way if you're switching someone. The cons of buprenorphine: there aren't enough doctors and other providers who prescribe it. There's certainly diversion concerns of it. There is withdrawal if you stop it, and stigma, just like with methadone. There's certainly stigma that we're always battling with buprenorphine. The cons of naltrexone are really compliance. So most people who get the Vivitrol shot, they get one dose of Vivitrol and then you never get another one, and that's very unfortunate. No help with pain. So obviously, if you're on naltrexone, not only is it not going to help with pain, it might interfere with pain treatment. We had somebody in a research study we're doing. It wasn't from our site, but it was in another site in the country. They were on naltrexone, Vivitrol, and they had a traumatic amputation of several fingers in their hand, and they found it extremely difficult to try to provide this guy pain management. He spent like 7 hours in some ER in New York, not getting any kind of treatment. It does cost a lot of money. Does it help with cravings? Yes and no. Depends who you ask. It's certainly difficult to get people on naltrexone, and of note, it does not lower ODs. In fact, we just had a paper that was an ASAM. One of the physicians sent it out, Dr. Berry, and on the opposite of not lowering overdoses, there was concern that the overdose rates were much higher on people that were on naltrexone as compared to buprenorphine or methadone. So we know for sure methadone, bup, lowers overdoses. Naltrexone doesn't seem to, at least in studies. Individual patients absolutely could prevent someone from overdosing if they're on naltrexone, but larger studies, not so much. Okay. All right, so what happens, we talk about overdose. What happens when you receive treatment with MAT? So this is a nice study done back a few years ago. These were survivors of non-fatal overdoses, so a lot of people. And what they found was only about 3 out of 10 received any kind of MET. So these are people that nearly died of an overdose. They're revived, and then out of all these people, very few of them actually received any kind of medications, which is quite frightening. Methadone for some of them, and these people tended to take it for about 5 months. Buprenorphine was a small percentage as well, people, and they received for about 4 months, whereas something now like naltrexone, much less people, and people would, again, only take it for about a month or get one shot, basically. The all-cause mortality at 12 months is pretty high in total, which is not surprising. If you have a bunch of people that nearly died of an overdose, they're more likely to die in the future. But treatment with MAT was associated with mortality reduction. For methadone, 53%, so much fewer people died on methadone. 37% with buprenorphine, so again, less people would die. And unfortunately, with naltrexone, is negligible. So again, just kind of a microcosm of many studies out there. Current treatment, I mentioned, again, that not a lot of people actually unfortunately embrace medication. So there's a lot of treatment out there, including in our state. There's over 100 treatment centers of some sort that are available in the state. There's a survey that comes out every year from SAMHSA, and this really, the results of the care reflects what's going on in outpatient, residential, and hospital inpatient. So you kind of lump everything together. In the US, 17,808, 116 in West Virginia. This is, again, 2019. Many of these facilities across the US, zero pharmacotherapies offered. So over a third didn't offer any of these medicines. So methadone, Suboxone, naltrexone, nothing. 50% offered no naloxone or overdose education. So this is naloxone. We're not even talking naltrexone, we're talking naloxone, Narcan. So no kind of education towards that, which is kind of unbelievable. So you have all these facilities, but again, a lot of them are not providing standard of care. Only 35% offered extended release naltrexone, which again, you think about it in terms of acceptance of medications, that's probably the most accepted one because it's not an opioid at all. Only 10% offered extended release SUBLOCADE, which we were certainly guilty of until recently, just more of out of an issue with insurances and the logistics of it, but very uncommon. We'll talk later about how much buprenorphine is offered, if any. All right, so now we have another quote because it's Valentine's Day, of course. After all, I'm just a girl standing in front of a boy asking him to love her. This one goes back a little bit. Anybody know it? Elizabeth, I'm expecting you to get all of these.
Katie got it, but Notting Hill, yes. With Julia Roberts.
Yeah. Yes, very good. And Hugh Grant.
Hugh Grant.
I have never seen it, but I did watch the scene. It's pretty good. So
It's worth it.
You need to watch it.
Yeah, it's very worth it.
okay, Katie's you're down with Notting Hill. Okay. All right. Once I get done with this, we'll watch some Notting Hill at my house. All right, methadone. So we're talking about methadone. So methadone, again, it's a full mu receptor agonist. It can only be given through an OTP, a SAMHSA certified OTP. They're the only ones who are allowed to dispense it for OUD treatment. Theoretically, any doctor with a proper DEA registration can dispense for pain management. So you will see methadone written through pain management. Often it'll be tablet form and like 10 milligrams 3 times a day, something like that. That's different than somebody in an OTP. CYP3A4 is the primary hepatic enzyme involved in the metabolism of both methadone and buprenorphine. So this can be very important because again, methadone, the safety window is different than Suboxone. So you're on a bunch of CYP inhibitors. Somebody might not need to be on a lower dose of methadone, whereas if you have somebody on a bunch of inducers kind of chewing through the medicine, they might need to be on a higher dose of it. So typically, the way that methadone is dosed, whether it's through an OTP or somebody's inpatient, is you wait till someone's sick, or if they haven't used opioids for a little while, you can just kind of start. But the initial dose is 20 to 30 milligrams orally, and you can give additional doses after that within a few hours. The maximum initial dose is 30, and the maximum daily dose, so day 1 dose, is 40 milligrams. So generally speaking, if we're talking about sending somebody from a coat type clinic to methadone, the most methadone they're going to get day 1, whether it's in the hospital or at an OTP, is going to be 40 milligrams. So this is from PCSS, a little bit more into methadone. So again, full agonist. It has a very weak affinity at the mu receptor, so that means it can be displaced either by things like buprenorphine, which is a partial agonist with higher affinity, or antagonists like naloxone or naltrexone. So somebody has too much methadone in their system, you could theoretically obviously give them Narcan, or if they still have methadone in the system and you give them buprenorphine or naltrexone, you can put them in withdrawal. You certainly want to monitor methadone. It can cause respiratory depression, respiratory arrest in overdose, and it does cause QT prolongation. It's very dose dependent. So labs, responsible dosing. Certainly methadone is a tricky beast, however, also very effective. Most similar to the opioids that people are using. Somebody have a question? Sorry. Okay, sorry. All right, so a little bit of the methadone maintenance dosing. So really the goal is to titrate to a dose that prevents opioid withdrawal. No big surprise there. You also want to reduce the opioid hunger / cravings, and ideally block or attenuate the euphoric effects of other opioids. So if you're on a good dose of methadone, people should look and feel pretty normal, but you also must ensure that they tolerate side effects. Sedation tends to be a big one with methadone. So if you push somebody too high with methadone, they will fall asleep. They will look like they're on medicine for sure. The target range tends to be 80 to 120 milligrams, which is much higher than the typical pain dose. Again, this is given once a day. through an OTP. You will see higher doses prescribed at times. I think the most methadone I saw was like 190-ish, although I've certainly heard of higher doses than that. That person was on a SIP inducer. They were on phenytoin, Dilantin, the anti-seizure medicine. Again, keep that in mind when you're dosing, if you're dosing. Interestingly, as much as there's so much regulation for the OTPs to be able to dispense methadone, to actually become a prescriber through an OTP is not all that complicated. So less training, not really any training compared to buprenorphine. When somebody's coming off of a methadone, it's typically very slowly, if you're doing kind of standard way of doing it through a clinic, so 10% every 10 to 14 days. So this can be a really long process. There are certainly other ways to do this inpatient if you're switching somebody off of methadone and trying to get them onto a different medicine, notably buprenorphine or naltrexone. All right, I'm not really going to go into the cross taper of methadone to bup, but suffice to say there are ways to go about it, similar to using naltrexone, where you kind of microdose very small amounts of buprenorphine. I've done it successfully about 6 times on the DDU. There are different protocols out there, but they typically involve very low doses of buprenorphine being added to methadone, and then methadone just kind of being stopped, because the higher affinity medicine, typically buprenorphine, is kind of replaces the effects of methadone. But that's kind of a lecture all into itself, and a research paper too, hopefully. All right, any questions about methadone? We don't use it as much, unfortunately, just given the availability of it. The fact that it's, there's only 9 sites across the state, and there really should be more than that. And that's hopefully something that will change in the future. So, all right. So buprenorphine, our old friend, it's a partial agonist, again, mu receptor, very high affinity, higher affinity than methadone. So we typically administer it sublingual, under the tongue, but there are also these other forms like buccal, transdermal, and now we have these depot formulations, which we'll talk about a little bit. The dosing varies. Typically what you will see is 8 to 16 milligrams. So that tends to be the sweet spot, at least of buprenorphine by itself. It's usually combined with naloxone. The induction, when we're doing it, tends to be with 2 or 4 milligrams, with a goal not to exceed 8 milligrams for the first day. So you will see people do this differently. Inpatient, you can be a little bit more aggressive because you have somebody there. But also you have to consider outpatient. If you're not treating someone's withdrawal, or you're way underdosing them, they may not come back to you. So it's a good idea to dose it responsibly and correctly. You can certainly precipitate withdrawal from full opioids when you're using bup, because it does have this really high affinity. So it kind of muscles off other opioids, whether they're methadone or heroin or even fentanyl. The minimal dose that you'll see is 2 milligram strips or tabs. The FDA recommended maximum is 24 milligrams, although you will see it prescribed up to 32 milligrams, including in Europe. And there's studies going on in the US too, of using these higher doses of buprenorphine. Depending on who you ask, I think with fentanyl, it has really changed the dosing of buprenorphine. You don't see as many people stable on lower doses of bup unless they were strictly using, say, pain pills. It's kind of rare to find somebody who's been using, heroin, fentanyl mixture that's floating around right now. It's kind of hard to find somebody who's using that who does well on 8 milligrams or 2 or 4 milligrams. So most people, you're going to see them on 12 or 16. And there are probably more people that should be on higher amounts. If you'd asked me this about a year ago, I'd say, very few people above 16. But I would say that a decent number of people probably should be on a higher amount, especially if they were into very, very potent opioids like fentanyl. So I'm kind of coming around to being a little bit more aggressive with dosing. The biggest barrier tends to be insurance, honestly, anymore with dosing above 16. I think the biggest risk of the higher doses is not necessarily, you're not going to hurt somebody per se, but diversion. That's really the issue when you get to the higher doses. All right, so the formulations, there's lots that exist. They are, again, often with naloxone. It's typically seen, pretty much always seen as a 4-to-1 ratio. So the sublingual films, Suboxone was originally a tablet. And then it switched to films when their patent was running out, basically. And now we do have tablets, but they're the generic tablets, still buprenorphine and naloxone. You will see Zubsolv occasionally used. So Zubsolv has a higher bioavailability, at least so they say. So the 5.7 milligram of bup to 1.4 of naloxone, that's actually equivalent to an 8 milligram dose of buprenorphine. So these lesser doses, but higher bioavailability, so something like this 11.4, that dose is actually equivalent to a 16 milligrams. So you'll see these used sometimes. Certain insurances, they're kind of second tier. Other insurances, you got to beg, borrow, and steal to try to get them approved. We also, occasionally you'll see a Bunavail used. I don't think I've ever prescribed it. Again, higher bioavailability, interesting, used on the cheek. You will see the mono products, which we don't tend to like to use too often, but the so-called Subutex, 24 411s, that's what's printed on them. But you'll see 2 milligrams and 8 milligrams. Probufene, that was the implant that we're not really, it's not being marketed anymore, but that's pure buprenorphine. Anytime we're using the injectable depot forms or kind of surgically implanted forms, those are just going to be the mono product. But the other one is Sublocade, which you are seeing more. So 300 milligrams and 100 milligram doses, which we'll go into a little bit. So again, major features of buprenorphine. It's a partial agonist. It has much less respiratory suppression and no respiratory arrest when used as prescribed. So when used as prescribed, that's normal dosing. That's no sedatives with it, or sedatives being monitored very closely. So with the high affinity that buprenorphine has, again, it blocks other opioids, but it can also displace other opioids, including methadone, and make people very sick. So something to consider when you are dosing it. It also has a slow dissociation from the mu receptor, so it kind of sticks around for a while. We had somebody on the DDU who got admitted over the weekend, and he had been on bup consistently inpatient for 6 weeks, rehab and detox, and then left, relapsed once on a lot of fentanyl, but woke up a few hours later and came in and got treatment. If he had not had Suboxone in his system, he probably would have died of an overdose. So he kind of had a partial overdose and woke up from it, but I can almost guarantee you the buprenorphine being there helped protect him. All right, so what is Sublocade? You're seeing it more and more, but this is an injectable subcutaneous bup solution. You got to refrigerate it. It's meant to be used for moderate to severe opioid use, just like other forms of buprenorphine. With Sublocade, if you're getting interested in dosing it and giving it to people, you need, per FDA labeling, somebody has to be on films for 7 days prior to films or tabs or whatever. But they need to have been on buprenorphine and found to tolerate it for at least a week prior to making the switch to Sublocade. All right, so there's only 2 shots available, a 300 milligram and a 100, and they're only placed in the abdomen. Indefinite length of treatment with Sublocade, so this, theoretically, you can continue to give it as long as the insurance is willing to pay for it. It is being very heavily marketed to various entities, including the legal system. I talked to a guy who runs a lot of the MAT programs in Pennsylvania, which was kind of interesting, and they're certainly using Sublocade. The way they're using it, though, is if there's any hint of misuse of Suboxone or Subutex or whatever in the prison system, So any kind of diversion that happens, then they're basically given the option to either stop taking oral sublingual bupe, or they can switch to SUBLOCADE, but they're not forcing everybody to make the switch, which is somewhat a fear I have. The dosing, again, it's recommended that you get 300 milligrams for the first 2 months, followed by 100 milligrams after that. Although you can increase back to 300 milligrams if people don't do well on the 100 milligram dose. So the cost is exactly the same, but Medicaid will not pay for it if you keep somebody on 300 without trying 100 milligrams. So it's something we've recently learned, because we finally had people consistently on SUBLOCADE. Sometimes we've tried to kind of keep people on 300, but you have to basically go 300, 300, and then drop to 100 and see how they do and kind of take it from there. The equivalent doses, it's a little fuzzy. Supposedly it's 8 to 18 milligrams versus 20 to 24, the dosing. I think we've experienced that it's probably not quite that much. People, especially that have been on buprenorphine for a long time, sublingual, Suboxone for years, the switch to SUBLOCADE feels a whole lot different. And it's just something, these numbers are nice and all, but clinical judgment is very important too. And if somebody tells you they're struggling mightily on SUBLOCADE, I would believe them, honestly. All right, so here's another one that might be coming out, fingers crossed. But this is another one called BRIXADI in the US, Buvidol in Europe, and you'll also see it called CAM 2038 used in the US. So this was approved in the EU since 2018. For them, it was their first approved long-acting bupe. So the US got SUBLOCADE, they got Buvidol. Same indications as the US. It was tentatively approved a few years back, actually. It didn't come to market though because of SUBLOCADE basically getting here first. So the FDA won't release two of the same medicines to the same formulations the exact same time if they're that similar. So basically the US chose SUBLOCADE, which we talked about, and the EU got BRIXADI, Buvidol for them. The approval was supposed to happen almost 2 years ago, but then it got delayed with COVID. And then recently there's been issues with the facility that produces it in the US, at least the kind that's being used in research studies. So stay tuned. I would have thought a few months back that this was going to get approved very soon, but I don't think anybody knows, honestly, when we're going to be getting BRIXADI. The uses are very similar to SUBLOCADE. Of course, it's for people who struggle with moderate to severe opioid use. You don't have to refrigerate it, so it's kind of nice. You can just kind of keep it in your office if you're doing research, but really it should be locked up. With BRIXADI, the dosing is different, where you actually have monthly and weekly formulations. So it's kind of nice that you can have some different dosing options. The idea is, which we'll talk about, is not really to keep somebody on weekly indefinitely. The goal with weekly is to basically assess tolerance instead of doing the oral buprenorphine for the first week, like you have to do the SUBLOCADE. You can essentially start somebody on BRIXADI pretty quickly. And you can use it in different areas, so you don't have to just stick with the abdomen. You can go to different sites for the injection. Again, we're kind of waiting final approval. There are some doses compared to subcutaneous, so you have daily compared to the BRIXADI. So a little bit more ability to sort of pick your dose. So I think we're using this in research, and it's definitely better tolerated than SUBLOCADE, and I would argue it's probably a little bit more efficacious too. So it's just nice that we're going to have more options going forward. Similar side effects, injection site type things that you don't normally think about with obviously giving somebody a film, but you got to pay more attention to injection site reactions when somebody's getting injection. That tends to be a big thing with SUBLOCADE to keep in mind too. All right. a little bit into buprenorphine. So this is kind of buprenorphine versus placebo versus methadone. Again, talking about how effective this is. So this is a meta-analysis. So buprenorphine is an effective medicine for retaining people in treatment at any dose above 2 milligrams. So people will stay in treatment, and suppressing illicit opioid use at doses 16 milligrams or greater. So people tend to do better on the higher doses. They'll stay in treatment at low doses, but they tend to do better at higher doses based on placebo-controlled studies. We don't do a whole lot of placebo studies now when it comes to MOUD. Buprenorphine appears to be less effective than methadone in retaining people in treatment if it's prescribed in a flexible dose regimen or at a fixed and low dose. So low doses of buprenorphine are really inferior to methadone, not surprising. However, buprenorphine, Suboxone prescribed in fixed doses, so above 7 milligrams, so 8 milligrams or higher, was not different from methadone prescribed at fixed doses, 40 milligrams or more per day. Again, methadone, 40 milligrams is really kind of starting doses. People are going to be on higher amounts in retaining people in treatment or in suppression of illicit opioid use. So once you get to higher doses of bup, it tends to basically be a wash between methadone and buprenorphine, which is a good thing. So lastly, on to naltrexone. Any questions about buprenorphine, BRIXADI, SUBLOCADE? A lot of clinical judgment with it. Certainly keeping an eye out for the precipitated withdrawal, although not being too terrified of it either is important.
In the chat, I see that David did ask about what about weekly and then BRIXADI. Did you want to expand on that at all, David, or was that kind of discussed?
No, that was
David?
it. I just hadn't seen it in his outline. So because they were
worries.
doing a clinical trial at Berkeley Medical Center. So they've been using the BRIXADI to bridge people to the programs, which actually is a really good use, I think. So,
but not
the
where,
ED.
not where they stay on it indefinitely, right? Just,
No, because we don't have it. So that's just, it was, I mean, I
minor
think it would,
details.
right, it would be good because we have a lot of patients, if you do get into the diversion question or not, that are still in the early phases. So I think it would be a great thing to have the weekly. I didn't know it was available on monthly too, but I have a lot of patients that want it and stuff. But yeah, no, it's just through the ED, through a trial through the manufacturer or, you know, something. So yeah.
So yeah, no, it's nice. So yeah, definitely with BRIXADI, Buvidol, whatever you want to call it, you've got a little more flexibility with the weekly, and then the goal is to get people on monthly, of course, if they're going to stay on the shot. Okay. All right. So on to naltrexone. It's a full mu receptor antagonist, so it blocks opioids. Very similar to naloxone or Narcan, old friend. Very few drug interactions, which is nice, but you do have to be careful in a compromised liver. It can cause elevated LFTs and such. So you gotta be mindful of that. There are only 2 formulations available, so oral tablets, which used to be called Revia, or the long-acting injectable, which we only have Vivitrol. I hope will go generic. The tablet formulation only comes in 50 milligrams daily. You can get pharmacies that compound smaller doses of naltrexone. So if you're prescribing it through a pharmacy, you're going to have to use 50 milligrams, maybe do a half a tab or, double it up or something. But through compounding pharmacies, hospital pharmacies, there are protocols where there's much smaller doses used. So the injectable formulation is 380 milligrams IM every 28 days. So it's IM, not subcutaneous. This is a big needle. Anybody who's ever given Vivitrol, which is a bit of an experience between mixing it up and then giving it, it's a very thick, viscous substance. It's very finicky. You have to, once you prepare it, you've got to give it very rapidly. Otherwise, it's going to kind of congeal in the syringe and just not be doable. Interestingly, there is some efficacy, just as an aside, because we're always complaining about methamphetamines, yours included, but there is some efficacy in combining injectable naltrexone every 3 weeks, which is kind of interesting, with daily extended release bupropion, i.e. Wellbutrin, for methamphetamine use. So this is a big study that came out about a year ago now. But sometimes you will see this if somebody's on, say, naltrexone, and for opioid use, and they're still using some meth, you could consider maybe combining it with Wellbutrin. It's very hard to replicate this every 3 weeks thing in real life, though. Good luck getting insurances to pay for that. All right, a little bit into naltrexone, the considerations. So it's recommended that patients be totally opioid free, followed by a wait period of 7 to 10 days before treatment can be started, because you don't want to get people real sick. This is a challenge, obviously, due to the need to tolerate withdrawal symptoms and be abstinent for 7 to 10 days. You can certainly use non-opioid medications to help during that period. Probably having somebody inpatient, residential, detox is the ideal setting to start naltrexone, because you have to get somebody through this kind of very delicate period. Oops. There are more rapid methods for naltrexone, which are being developed. So there are microdosings where you will see somebody be started on really tiny amounts that, again, some pharmacy has compounded because you can't get them that dose, but really low amounts of naltrexone given and kind of work somebody up to getting a shot. Before you give the shot, it is probably best practice to do an oral challenge with naltrexone. You'll sometimes also see naloxone given, so a Narcan challenge, obviously not oral, but you want to make sure somebody tolerates naltrexone before you give them the long-acting injectable Vivitrol. So typically what I would do is give them, 25 milligrams. If they do okay with 25 milligrams, half a pill, which is easy to obtain, then you give 50 milligrams. And again, if they tolerate it for a few hours, then you can give the Vivitrol shot. You can be a little more conservative if you want, kind of extend it over a few days or a week. But you have to be pretty bold to just give somebody Vivitrol without testing them first. All right, a little bit into naltrexone, again, complements of PCSS. It's a full antagonist, competitive binding at mu receptor. The oral doesn't have that long of a half-life, and the oral is not recommended in opioid use. So really the IM, because of the longer half-life, the depot formulation, is very high affinity for mu opioids. It blocks other opioids. It will displace other opioids. That makes people sick. And then you have these, the tablet formulations and the Vivitrol formulation, both of which were originally approved for alcohol. And then their indication is expanded to opioid use. So in terms of mu opioid effects, so full agonists like methadone, morphine, of course, you can have much more profound effects. Something like buprenorphine, less effects, or something like naltrexone, naloxone, really no effects. And if you give one of these, you're going to drop somebody down into withdrawal, drop somebody. The biggest drop would be going from full agonist down to an antagonist. But even from a partial agonist, an antagonist can be still very uncomfortable. All right. Any questions about naltrexone? We're almost done, I promise. All right. So last cheesy quotes of the day. You complete me. Pause. Other person. Shut up. Just shut up. You had me at hello. Had to add the shut up. Just shut up part. You had me at Top Gun.
Yep.
Not Top Gun. Not Top Gun, but
Jerry Maguire.
Jerry Maguire.
very good. Very good.
That's right.
Close though. Same lead actor. Very good.
All right.
Jerry Maguire. Okay. Yeah. All right. So last on SUD treatments. So facilities that offer buprenorphine, again, there's what, 17,000 in the US, 116-ish in West Virginia. So ones that offer buprenorphine with naloxone, only 38% offer any kind of Suboxone. So most places do not offer any Suboxone. Without naloxone, so Subutex, only 27%, most do not offer it. So buprenorphine in general is not used nearly as much as it should be by treatment facilities. And I always question, should we really even call them opioid treatment programs if effective OUD treatment is not being offered? So question that. So conclusions, it's a gold standard using medicines. That's the only medically ethical and efficacious treatment for opioid use disorder. There's 3 medications. They all have their pros, they all have their cons. The dosing medications is dependent. There are some, certain things that you follow. You can't really kind of half dose a Vivitrol shot, but many facilities, unfortunately, do not follow the standard of care. And again, not just prohibiting methadone or, inpatient, or I should say buprenorphine mainly, but also prohibiting things like naltrexone, Vivitrol, which I just don't understand. Lastly, happy Valentine's Day to everybody. Hope you enjoyed the quotes. I really, I want to watch some of those movies again, except Twilight. Twilight stinks. So. Anyways, sorry about that, Elizabeth. I know it's your.
Whatever.
What team were you on? What team back in the day?
Edward.
Of course. All right.
Duh. Well, my husband's so white. So like, I mean, he's like a vampire in of itself.
So white, he's a vampire. All right. Anybody have any questions? As we kind of do more of the more interesting things, the naltrexones, like that, or stop sharing my screen. But as we start doing some of the more kind of interesting tapers and things, and cross tapering, micro dosings and all that, stay tuned, and I'm sure we'll teach you some of it. Echo. I don't know if anybody else has tried it, but it's, there's some interesting ways to go about these different medicines. Again, I look at it, think of it as it's very easy to go from naltrexone to bup to methadone. Much harder to kind of work backwards sometimes, but doable still.
Well, thank you so much. As always, you do such an excellent job, Dr. Husted, and throw in some fun in there too. So appreciate that. I have a raised hand and also a really quick question in the chat from Dr. Gorby. What percentage of treatment centers offer Suboxone?
Well, I think that was answered, but not nearly as much. So what, 37-ish% in total across all the sites in the US. I don't know if it breaks it down by state. I've never been able to find that, but I was talking to one of the fellows about this. I would guess it'd probably be maybe a 20-25%, if that, in the state actually offer bup, which is kind of sad. But
Thank you very much. And then David, go ahead and
Yes. So Jeremy, your lecture is probably much better after being sick than many people without being sick. So good job. But
well, thank you.
what about the precipitated withdrawal? I haven't faced too much of that, even with fentanyl around. A lot of our patients are already coming in, but I have one patient that last year she relapsed and was on fentanyl, and I had to actually put her in the hospital because she just kept throwing up. And it's the first one I'd done, and it was really hard to gauge. Same thing happened again. She had more of a lapse, not a real big relapse, and wasn't using fentanyl a lot, but had the same reaction. So I don't know, is that precipitated withdrawal? Is it psychosomatic? She was all into the burn method, all these, microdosing and stuff. And so the second time I found it a little harder to buy into. I still treat, I did the, smaller doses, gave her Phenergan, all those things. But any suggestions or experience with that?
Have you tried different formulations of bup? Because I will say some people just, for whatever reason, don't do great with films. I've been a little bit more, the way I see it is, if somebody's not going to tolerate films, you might as well try generic tabs.
Right.
I mean, have you tried that at all? Because I've had some people that just couldn't do well with the films.
Yeah, it's been really good when Medicaid covered the tablets now, because I have a lot of people that have switched over just because of the taste. But she'd been on films for years, so it's not. I mean, she tolerates it fine.
Yeah.
And then had 2-3 days of a little bit of it's fentanyl out here, all of it. There's no heroin. And then she just said, she wasn't even. She was withdrawing, but she'd take it and she'd throw up all the time. So kind of my impression was it's almost more psychological, kind of, with the relapse, all that psychology going involved.
I don't believe in any of that psychology nonsense, but anyway.
Okay, good. Just medication, right?
No.
Just medicine, right?
Medicine. I love it. Anyways, actually, we have talked about it in one of our research calls, because we've been talking about sites all across the country. And some people, besides fentanyl and carfentanil, there's some analogs with real long half-lives out there.
Is that the nitazene or something? I just read about that in the Washington Post.
I think it's a real thing, that there are some people that their precipitated withdrawal lasts for a long time, even at pretty small doses. So I wonder if some of it could be psychological. It is. But anyways, and there are definitely some fentanyl analogs out there that do some strange things, and don't really respond to bup. until, you know, a week or two later, which is crazy to think about. And some people, honestly, I think some people might honestly just do better on methadone.
Okay.
You know, we'll see. But yeah, good luck with her. I hope
Yeah. Yeah, she went to rehab today, so we're good.
one that accepts medicine, right?
Yeah, I mean, that's the only people we send, you know, so, you know, yeah, I don't think it's, yeah, I agree with you. It's malpractice.
Yep.
So.
Jeremy, I wanted to say something about a blocking dose, you know, that kind of the thinking behind methadones of efficacy.
Yeah.
And, you know, my work with methadone predates people using fentanyl, and the affinity for fentanyl is so high that a blocking dose becomes much more difficult. And I think that's even true for buprenorphine, you know, that fentanyl can compete away buprenorphine. So what is our thinking about preventing euphoria when people use opiates now, if we can't block the pleasure from people using it? Or what do you think about that?
I think it's a problem. I think fentanyl is the worst. And yeah, the euphoric, blocking the euphoric effects. And, you know, I think sometimes it is going to take just mega doses of these things. With bup, you have the, you know, the benefit of you're not going to hurt somebody with huge doses of bup. As long as they take it, you know, you should still concern yourself with diversion. But with methadone, you don't have that luxury. Really high doses of methadone, you could seriously hurt somebody. So I don't know. We need some supercharge. I don't, you know, something even with higher affinity than fentanyl, and then they'll come up with something that has a higher affinity than that. I'm sure. But it's a delicate dance we have with those opioid receptors.
Thank you so much. We just have a couple of questions and we'll make that final announcement since we're down to a minute. How did SUBLOCADE patient do that was denied by insurance for 300 milligrams at the 3rd month before being on trial on the 100? Does anybody know about that?
We're about to find out because the one
Okay.
got it last week and the other's getting it this week. So I'm curious. I'm curious to see how they do. I hope they do well. I'm holding out hope. What I plan to do is if they don't do well, I will give them films on top of the depot. So there's nothing wrong at all with giving somebody films on top of it. You're not going to hurt them.
Excellent. And any other questions that come in, I'll just reach out to Dr. Husted and see if I can just include those in the recap since we're down to that minute for you guys. And I'm sure you want to go do what you got to do. All right. Our next session, but sorry, Jeremy, go ahead.
No, nothing.
Okay.
Again, just remember Buffalo plaid is the most romantic thing to wear. So
Yeah, I need to go buy some right now.
very good.
February 28th, Katie will be
Very nice
discussing
day.
ethical considerations for SUD.
I don't think I can because I don't have buffalo plaid. I'm gonna have to borrow Jeremy's coat for that.
Yeah,
Fine,
you're
it's
gonna
all
have
let
to.
me.
hanging up on my thing. All right,
Okay,
everybody stay well.
Thanks,
guys.
everyone.
Bye.
Bye-bye.
Yeah.